is entitled Heart Failure Centers of Excellence in Jordan, the Needs, the Burdens, and the Proposed Plans. I'll be honored to coordinate this session with my friend Dr. Balbisi. Qais, please join me. Is Dr. Ashraf Samen here? No? Munir Zaqqa? No? Okay. Awaisheh? Ibrahim al-Abbadi? Please, Abu Samen. Nammas? Oh, here's Munir. Come on up, Munir. All right. Without due time, Qais will take over and introduce.
Okay, go ahead. Dr. Munir wants to go ahead, Dr. Munir. He wanted it. Dr. Munir, go ahead.
السلام عليكم. نبدأ الجلسة القادمة. طبعا يشرفني أن أقدم الدكتور نزيه القادري. Dr. Nazih Qadri is senior electrophysiologist in Jordan and also has interest in heart failure. So he will start talk on centers of excellence in heart failure.
I just wanted to point out that Dr. Ahmad Turk, who is a heart failure specialist, we would have loved to have him with us, but he's not available physically. And Dr. Nazih kindly agreed to present both of these talks, and we thank Nazih for doing it, actually.
Actually, I was asked from some other institution, private of course, in Jordan to talk about excellence in heart failure. And then Dr. Hadi asked me to talk about the same talk. But the situation is different, and this is along with the discussion that was happening. Being at Naqabe is different from being in private practice. And what Naqabe does is different from what we do in private practice hospitals. So this is why I thought of this presentation, talking about pillars of excellence, which denotes how I see how it needs to be to improve heart failure treatment and other needed projects. So it is my pleasure to share with you today the vision and role of the Center of Excellence in advancing heart failure care in Jordan and across the region. This is not just about concerns or concepts or titles. It is about transforming daily clinical practice into a unified, effective model that delivers the best possible outcome from our patients. The vision of the Center of Excellence, and this is all points of view that I'm talking from Naqabe, is unifying heart failure and electrophysiology care for Jordan and the region, because actually electrophysiology and heart failure are really intertwined. Our mission is to harmonize care standards, integrate discipline, and elevate outcome. Why our mission is of value? Doctors in our region previously relied on, actually and currently, relied on American, United Kingdom, European guidelines that are based on clinical evidence but did not always fit our local and regional needs. And actually, we're different in terms of our genetics. Modern Medical Association established a national framework to align practice with local evidence and context. The Center of Excellence in Heart Failure applies these standards, converting them into unified clinical system and training. This ensures care reflects Jordan's realities while maintaining a global scientific integrity. And I've been talking on this slowly because this is really important. So how are we going to do it? There are 7 pillars of excellence, as you can see in the background, Ahmad, that we're going to rely on to reach what we need. So the first pillar of excellence is unifying clinical standards. Second, integrating electrophysiology. Third, training with capacity building. 4, with research and registry. 5, technology and innovation. 6, quality assurance, acceptance, accreditation, and regional calibration. Regional calibration, and I mean interaction and these kind of things. First, talking about pillar of excellence of unifying clinical standards and protocols. So we work to ensure that every hospital and medical center treating heart failure patients follows the same up-to-date evidence-based guidelines. This means harmonizing diagnostic criteria, treatment pathways, and follow-up protocols. For example, standardized approach to cardiac function monitoring is like in CRT programming and device programming. The second pillar of excellence is integrating electrophysiology and heart failure care. We bring the expertise of electrophysiology into every stage of heart failure management, from cardiac resynchronization therapy to arrhythmia management to for optimization of implanted device. This integration directly improves treatment effectiveness and reduces complication. The third pillar of excellence is training and capacity building. We organize training programs and workshops for physicians and trainees, including general cardiologists and specialists, and we support the optimization of new heart failure units in under-resourced areas. And when we talk about under-resourced area, we're thinking about the south, the north, Amman, and all of these areas. The goal is to empower local physicians to become leaders in both heart failure and electrophysiology. And the fourth pillar is research and data registry development. We aim to build a national heart failure registry if we can. That includes rhythm-related data and device intervention records. This establishes high-quality studies on atrial fibrillation, conduction disease, CRT outcomes, and more, supporting evidence-based decisions and improving care across Jordan and the region. Technology and practical innovation is the fifth pillar. We focus on practical, available solutions rather than costly, inaccessible technology. This includes maximizing the use of ECG in clinics. Many times I get patients from outside, north or south, and there is no ECG. And hospitals structure follow-up schedules for patients and leveraging an existing medical software for arrhythmia analysis and device optimization, all without placing extra financial burdens on patients. The sixth pillar of excellence is quality assurance and accreditation, and this is very important. We monitor performance through regular audits and outcome measurements. We aim for interventional recognition centers that meet high quality benchmarks such as JCI accreditations and or ESC or any other one in heart failure certifications, thus aligning local care with global standards. And actually, this is a very good start of it. I mean, what we're doing now. The seventh pillar is we represent Jordan's heart failure community in regional conferences and joint initiatives across the Middle East and North Africa. We are building a strong network of expertise, exchanging knowledge and positioning Jordan as a hub for integrating heart failure electrophysiology care. And that is hopeful. We don't have it yet. We are very scattered a little bit. Though I get patients from North Africa, from Iraq, from beyond Iraq, and from everywhere. But we need this kind of thing so that it will be better and more successful. So closing message, through these pillars, the Centers of Excellence become a true platform for unifying efforts, improving care quality, empowering physicians, and delivering better outcomes for our patients, both here in Jordan and across our region. I'm going to follow, actually, my friend could not be here and he traveled, I hope nothing wrong, out of the country last night. So he gave me some slides to talk about, but actually I cannot go into his brain and talk what he wants from these slides. They sounded like general. So I'm going to read them like the way I read them now, but those I am reading them understand what I'm saying. Here I may not be that much. I'm sure they will complement what I have said on a level of hospitals here in Amman. Heart failure cardiologist leads clinical decisions making and advanced therapies evaluation. By the way, I got these slides at 10 last night. Sorry. Cardiac surgeons input mechanism, circulatory support, LVADs, transplants, etc. Ancillary staff, pharmacologists, medications, optimization, polypharmacy review, adherence support, cardiac imaging, specialist, echo, MRIs, CT scan, nuclear cardiology, for diagnosis and programs, and this is meant the staff in Excellent and what needs to be done, and the group. Assessment, electrophysiological, and primary care physicians. And he has this model that talks about how the communications and the interactions between the heart failure specialist and all others, including cardiac surgeon, pharmacists, imaging specialties, electrophysiologists, ancillary staff, and what have you. And this cooperation needs to be done in a good way, and excellent communications, and always going to the heart failure specialist, which can be carried over. The guideline structured function that he has, he talked about diagnosis and risk stratification, which means standardized use of biomarkers, if possible, imaging, like complete echo, including hemodynamic care, MRI, functional assessment, NYHA, 6 meters walk, etc. Functional assessment, it can be done in other different ways, probably O2 consumption on stress test. The pharmacological optimization includes optimizing to target doses in treatment, as mentioned here several times. Diuretics management protocol, and there are so different opinions, and this needs to be standardized. Guidelines directed use of ivabromide, hydralazine in selected patients. Actually, I had a patient here at Abdali, and we consulted Dr. Turk, and amazingly, he did a wonderful guy. Patients, we thought she is going to die, and then was discharged 7 days later by using these medications. Device therapy, MDT evaluation for ICD, CRT, conduction system, pacing, shared decisions, making pair guidelines, thresholds. The fourth is advanced therapy, which means LVAD, which we talked about today, candidacy, use intermax profiles. Heart transplantation evaluation, I hope it comes back. ECMO on temporary MCA is acute decompression. I'm sorry here, but I did not know what somewhere, but talking about ECMO, that needs to be here. The fifth is comorbidity management, diabetes, as said, chronic kidney disease, COPD, iron deficiency, etc. Sleep apnea and obesity program, as just said previously. Palliative treatment, symptoms control alongside disease modification, therapy, advanced care plan, integrated early, patient report outcomes. 7, follow-up and transition, structured clinic visits, early, post-discharge. This is routine in USA where I practice so long. Telemonitoring and remote patients management. The last is quality meters, adherence to and hospitalization readmission rates. So, weekly MDT meetings, case discussion, complex cases, advanced therapies, share EMR notes with MDT inputs visible to all members, decisions, algorithm based on guidelines. So that's what he's written, and I'm sorry, I just read it without anything about it. The situation dictated so. Any
Thank you. Thank you, Dr. Nazih. We'll leave the questions till the end of this section. Our next speaker needs no introduction, Dr. Firas Bader.
Nazih, come join us here, please.
Dr. Firas is really a pioneer and a leader in treatment of advanced heart failure. He has established a lot of programs, both in the United States and the Middle East, and he's helping in Jordan. But I do want to say one thing about Dr. Firas, truly. Not only is he a pioneer and advocate for science overall and in the world, he has been a great help to our Jordan programs. Thank you, Dr. Firas. You've always been great. And I would like to extend you our deepest gratitude from the Jordan Cardiac Society to all your help and support. Please,
Thank you very much for the kind introduction, Qais. Thank you, Dr. Hadi, and the rest of the panel. And it's a great pleasure to be with you here to discuss this topic of advanced heart failure and transplantation in the region. I'll give you my regional perspective, having spent the last decade working with different countries in the region and also helping to establish some of the programs and also publishing some literature in this. So I want to summarize it in the next 20 minutes to give you some overall view, and hopefully that will be helpful as we embark on this rejuvenation of the advanced heart failure therapies in Jordan. So I will discuss quickly what's happening with heart failure globally, what's happening in the region, what was achieved, and what else is needed. This is a paper that came out from the European Society of Cardiology a couple of years ago about global burden of heart failure, supposedly representing the entire world, a comprehensive and updated review of epidemiology. And it concluded that prevalence of heart failure, the slides are not on the screen. Thank you. Thank you. So this is the European report on global heart failure burden. Prevalence was concluded to be on the rise, but mostly on heart failure and preserved ejection fraction because it's an entity that we've been doing a better job diagnosing. Mortality remains high with approximately 50% death rates at 5 years. And of course, the cost is increasing worldwide. If you look at this report and you quickly scan what was included in the European Society of Cardiology report, you see no mention of the Middle East region or any country from the Middle East in this report. So when we say global report, you'd hope that there is some representation of our region, but our region is not included here at all. This is the Heart Failure Society of America updated report on epidemiology and outcomes of heart failure. And it starts by saying that the lifetime risk of heart failure is 1 in 4. So we're dealing with a significant pandemic of heart failure, and we'll continue to deal with it as years go on. Of course, this is something that happens more with age, and this is not a secret to any of you. And the cost in the US continues to also rise because this is something that results in a lot of hospitalizations, and hospitalizations cost a lot of money. This is the global map of outcomes for heart failure, and if you focus on our region, you'll see that the reported mortality is mostly in light colors, but I would argue this is not because the mortality is low in our region. It's mostly because the reporting is poor from a lot of the countries in our region. Some of the countries that did registries, as the registry we heard this morning, have reported outcomes, but the rest of the region in the Middle East do not have any clear data as far as outcomes. Heart failure stats also indicate that there is a split between heart failure with preserved ejection fraction and heart failure with reduced ejection fraction, and that the mortality is really very high, approaching 75%. Again, people die of cardiovascular causes or non-cardiovascular causes as you move from reduced to preserved ejection fraction. Cardiovascular causes for death become less, and non-cardiovascular causes for death become more with the preserved ejection fraction, but there's still cardiovascular death there. In fact, there is still even sudden cardiac death in patients with heart failure and preserved ejection fraction. This is the map of the Eastern Mediterranean region as defined by the WHO. The Eastern Mediterranean region is a region that extends from Morocco all the way to the west. The display of the slides on the screen is not like on my screen, by the way. Okay, but no, on the screen, it's not the same like this screen. It's not zoomed in. Anyway, so it's extending from Morocco in the west all the way to not Iran, to actually Pakistan. This Eastern Mediterranean region is about 750 million people. So this is double the size of the United States in population, double the size. And if you look at the numbers of advanced heart failure therapies and heart transplant in particular, coming from this region with 750 million, you realize that what we're doing is nothing compared to what the Western world is doing. Okay, thank you very much. Now the map is clear. I didn't want people to think that the Middle East map has changed already. It didn't change. Still the same for now. This is the world population and the percentages of heart transplant. If you look to the left, Asia represents 2/3 of the world population. If you look to the right, Asia represents less than 10% of heart transplant. So 2/3 of population, 10% of heart transplant. That means we still have a lot of work to do in this entire region. And I'll start to show you some of the data that we have from the region as we collected it over time. This is the International Society of Heart and Transplant registry, and it shows you in green the transplants that have been done in North America, in blue the transplants that are done in Europe, and then we're starting to see increasing transplants in Asia because more centers are rising and starting to do heart transplant, still way less than should be done. Another problem of underrepresentation is even coming from within the region itself, from within our continent. This is a paper that I came across from Jack Asia that talked about the burden of heart failure in Asia. And it concluded that China, Indonesia, and Malaysia are the highest 3 nations in terms of age-standardized prevalence of heart failure. But when you look at the map carefully here to the left, this is from the paper itself, you'll see that the Middle East was completely excluded from the map. Interestingly, when you analyze the countries in the Middle East that belong to Asia, the Middle East region has the largest number of countries in Asia among all these other regions. And when we looked at this, we realized what mistake they made. When they tried to analyze this by regions, they only included the regions that had the word Asia in them. Central Asia, East Asia, high-income Asia Pacific, South Asia, Southeast Asia. So the Middle East was not included. So this was a misrepresentation of the data. So what we did is we wrote to the journal. We wrote to Jack and we said, this is wrong. This is not the true picture of heart failure in Asia. And we corrected that by sending them a letter. And we said, this is the map of countries in Asia, and it includes the Middle East region. And we did repeat the same analysis that they did. Same data, we reanalyzed the data one more time. And we concluded that the top 3 countries in the prevalence of heart failure were actually China, Kuwait, and Jordan, believe it or not, based on the data that they used. We didn't change anything. And when we looked at the change over 30 years, the top 3 countries, as far as change in heart failure from where it was 30 years ago to now, was highest in the Middle East, in 3 countries, the change. Syria, Saudi Arabia, and Oman. So we do have a serious problem of heart failure in our region. What about advanced heart failure? We did an analysis of the global burden of disease over 30 years, 1990 to 2019, and we utilized this data to look at advanced heart failure, specifically as defined by NYHA class 3 or 4, which is the definition they use. And we analyzed the data to see what's happening with advanced heart failure in our region compared to the rest of the world. This is what's happening globally. This is what's happening in the regions of the Americas. This is what's happening in Europe, and this is what's happening in the Eastern Mediterranean region, which is the region I showed you the map for. The cases of advanced heart failure are actually going up, they're not going down in our region. And we looked at years lived with disability, and this actually accounted for almost 180,000 years lived with disability in the Eastern Mediterranean region. When we tried to zoom in to see which countries had the biggest burden of this advanced heart failure, and we looked at this data specifically to see among the countries in the region, which countries would have the highest change, it was countries in the Gulf region. But I would also argue that it is simply because cardiovascular care improved significantly over the last 30 years in the Gulf region, and reporting also improved, so the data concluded represent the highest change in advanced heart failure. I would argue that the rest of the Eastern Mediterranean region also has significant increase in advanced heart failure. And again, countries like Oman, Bahrain, UAE, Saudi Arabia, and Qatar experienced the highest growth in advanced heart failure burden over these 30 years. This is also work that we published already. So what we need is multidisciplinary programs that do optimal medical management, early referral, and also establish advanced heart failure therapies across different countries. And this actually makes a big difference. This is a status of advanced heart failure as it is today in the Eastern Mediterranean region. We looked at this as a kind of a milestone paper to tell everybody what advanced heart failure therapies look like in the entire region. By the way, I guess you guys put 10 minutes for me, but in the agenda, my presentation is 20 minutes, just a correction. I didn't want the panel to think that I'm over time. The first heart transplant in the Eastern Mediterranean region was, of course, done by Dr. Dawood Hanania. We take pride in saying that this first heart transplant in this entire Eastern Mediterranean region was in 1985. This was followed by Saudi Arabia in 1986, Syria in 1989, Iran in 1993, Tunisia, Lebanon. We started the program in UAE in 2017, and Kuwait started in 2019. Mechanical circulatory support started in the early 2000s at King Faisal Specialist Hospital with the HeartMate 1, the first generation of the assist device. And then, of course, other countries followed. Like I said, in 2008, there was a HeartMate 2 planted in Qatar, and then in Lebanon in 2009. In our program in UAE at Cleveland Clinic, Abu Dhabi, we started in 2017. This is the published experiences of left ventricular assist devices in the Eastern Mediterranean region. And as you can see, in the region, patients tend to be a little younger compared to patients from other countries in the West. And we have a similar mix of ischemic and non-ischemic cardiomyopathy. But this is what happened with heart transplantation in the Eastern Mediterranean region. The reason we picked 2019 here is that we wanted to isolate the effect of COVID. We didn't want the numbers from COVID to cloud the conclusion from what's happening in the region. And as you can see, in 2019, only 180 transplants were done in this entire region, which is again 750 million people. In the US, they do between 4,000 and 4,500 heart transplants. They are half the population of our region. And when we asked people from this region what happens to these patients with advanced heart failure, we concluded that only 59% of countries do not have any advanced heart failure available. That's almost 2/3. Heart transplant and LVAD therapy were only available in 1/4 of these countries, and LVAD therapy alone was only available in about 14%. Number of centers performing advanced heart failure therapy were 26 for heart transplant and 18 for LVADs in this entire region. And number of cases, like I said, about 180 in 2019. Most common indication for LVAD therapy was destination therapy, simply because these programs did not have a bridge to transplantation. We asked these people from different countries, what happens if you don't have advanced therapies in your region? And we concluded that about 54% end up sending patients elsewhere. But of those 54%, only 40% of the time, patients are covered by their governments. So which means that all of the other patients that are sent out are paying out of pocket, which again raises the issue that countries need to have their own programs as opposed to letting their patients go and paying out of pocket in other countries. And countries, as mentioned in the previous session, included USA, India, some European Union countries, China, and sometimes Saudi Arabia, especially from within the Gulf countries. But this is the organ donation in the Eastern Mediterranean region. It increased, but is still suboptimal as far as we know, considering the demand that we have. And this is what happened over 20 years for Asia as a continent. In red color, you see the heart, and the heart still represents a very small percentage of the total transplants done in Asia. We really need more heart transplants than we have today. But until we have more heart transplant programs, we can have more mechanical assist device programs, because these people can be on these assist devices like the HeartMate 3 and live for many, many years without needing a heart transplant, considering how advanced the technology has become. A few words about our program in Abu Dhabi. We've done a total of 38 heart transplants, 13 this year alone. We're on pace to finish the year with about 20 heart transplants. The system in UAE follows a very, very important human principle. If everybody is donating, everybody can receive, which means that of the 38 heart transplants, we have 60% that are Emiratis, and then 40% that are non-Emiratis from all over the world. In fact, you don't even have to be a resident in UAE to get a heart transplant. Even if a visitor comes to the country and needs a heart transplant, the patient can be listed and can get a heart transplant, something that doesn't happen in any other country in the world at all. And we've done all kinds of combinations. So we have patients who were bridged to transplant from balloon pumps, from ECMO, from Impella, from assist devices. All these kinds of combinations were done. And of the 38 cases, we've done 2 cases of combined heart and lung as a block in patients with severe pulmonary hypertension. Our survival rate is 90% at 1 year, which matches the survival rate of North American programs. And these were the referrals. We got referrals from all these countries. And like I said, we don't turn anybody away. Everybody is welcome, if needed, to be evaluated and be listed for transplant. We need multidisciplinary teams. I can't emphasize this point enough. We've heard Dr.Nazih, but we really need more of these programs to be established. We need at least one full multidisciplinary team to be able to deliver these therapies down the road. Guidelines stress that, and we have to follow the guidelines, whether it's locally or internationally. We implemented this in our program, and this was our publication on the first dedicated inpatient service. So not just having a multidisciplinary program, but having a dedicated inpatient service for heart failure. And when we established this dedicated inpatient service for heart failure, separate even from the general cardiology service, we ended up reducing hospital length of stay, we reduced 30-day admissions, and we scheduled everybody to come to clinic within 7 to 10 days without any exception, which improved outcomes later on. So how do I see the future? More advanced heart failure transplant programs will be established. Referrals will happen more timely to allow complete evaluation and listing for transplant in a non-urgent manner. Organ donation will hopefully continue to improve and become a more regulated process. Ideally, more regional coordination and collaboration will take place between different countries to increase the numbers. My take-home message is markers of heart failure epidemiology are worsening globally and regionally. The cost of heart failure continues to rise. More work is needed for better regional representation and outcomes. and it all starts and ends with multidisciplinary team. I'll take this opportunity to let you know of our calendar under the Middle East Heart Academy. We have an upcoming Advanced Heart Failure and Transplant Conference that we do in Abu Dhabi that is just dedicated for LVADs and transplants, end of October. We have an update on cardiomyopathy conference in December. And of course, our biggest conference is the Middle East Heart Failure Conference, which takes place in January. This is open for you to submit abstracts. This is to the students and trainees. Submit your abstracts to this conference because the top abstracts actually receive awards at that conference, including some travel awards to go to the conference. We have a dedicated cardio-renal forum in February, and we have a cardio-oncology conference in April. And with that, all of these conferences will be free for you to attend if you are a member, and membership is totally free for students and trainees as well. Thank you very much.
Thank you very much for please join us on the podium. When we start, I think we have a good 10 minutes to go over, and I'm happy to tell you that if we finish the way we're going, the whole today in the morning will be probably too active. For us, it's just so mesmerizing to me when I think of the lack of advancement or advanced stage heart failure here in Jordan and in most parts of the region. And when you think about cost effectiveness, can you think about how much money it costs people? We all encounter that an end-stage heart failure patient sitting in the CCU or the ICU a week, 2, a month, what have you. And usually they end up with not a very good outcome. From a cost effectiveness point of view, even, it doesn't make sense. Any comments on that?
Thank you very much, Dr. Hadi. Yes, from a cost effectiveness perspective, it doesn't make sense at all. However, let me stress that worldwide, including the region, sometimes this cost effectiveness equations seem differently between the public sector and the private sector. What I mean by this is that the public sector is interested in reducing the emissions for heart failure because it's a burden on the healthcare system and they want to take care of everybody. But some private sector hospitals may not address this as an issue because they are getting paid for these emissions. So it has to come from the top. It has to come at the policy making level to enforce that admissions for heart failure are bad, whether patients are coming to private or to public hospitals. And the way to do this is to hold hospitals accountable if patients stay in them for a very long time, and even penalize them like they did in the US if patients are coming to the hospital very frequently, which will push everybody then to work harder towards managing patients better, because nobody wants to suffer the consequences of the government tracking them and trying to put like fines or pressure on them to limit admissions. But cost effectiveness is a true thing. If you admit people less with heart failure, you will save the country money at the end by having them on the right track.
Thank you.
I have a question for Dr. Nazih. Do you think we can establish in Jordan like a committee to accredit hospitals directly with the excellence in heart failure management, for example, or something like that?
Having so many patients coming from so many times and from so many different areas, especially from the north and south, and staying in the hospital at times, they almost completely do a suicide thing by saying we don't have the money, they're done, and they leave the hospital. And this is what I meant when I said it has to be coming from the maqabir, so to speak. put guidelines, have hospitals where patients can go if they have chronic disease, talk to so many committees, make some committees, and educate the distant physicians on heart failure management. Actually, this is the way to solve it in Jordan. I get a patient from Irbil. Why? Because he is short of breath. Why did you go to Irbil? I don't have a good physician. So, you see what I mean? These need to be educated, and this is the thing. And I think in Jordan, this can be done so easily if we put our minds in it.
Yes, I want to give a question for Dr. Firas, please. If you can give us a quick criteria and priority for patients for heart transplant. This will help our students to know about this.
Thank you very much, Dr. Ibrahim. I think in simple terms, so it's not complicated. If your patient is on adequate medical therapy for heart failure, and now they're coming to the hospital frequently despite being on therapy, this is a red flag. If they have ICDs and they are receiving repeated shocks now, it's an important red flag. If they are having consistent low blood pressure or progressive worsening of kidney function, it's a red flag. And if you're having to decrease their medications because they cannot tolerate medications anymore, this is a red flag. Of course, this is all in the background of poor LV function and symptoms with minimal exertion or at risk. If these things are seen in your patient, you have to start thinking about advanced therapies, and you have to start thinking about referring the patient to be evaluated for another option. That could be heart transplant if they're relatively young. And if they're old and they're not candidates for heart transplant, they can at least get the computer assist device as a destination therapy, which will be enough for them to live for many years without having any heart failure.
Thank you.
Funny enough, we have to make jokes sometimes. I hope it's an irony. We live in the Middle East, and look at us talking about cost effectiveness in medicine and saving lives. That's what we want to do. Can you imagine what an F-16 costs and how much money you can invest in all the Middle East, across all the Middle East countries, for giving assist devices for all patients with heart failure? It's an irony, but it's sad. It's very sad. Very sad. Thank you very much.
Since you know, the idea of this conference is also to come up with recommendations. So if you want to sum it up, I would say we all agree that we need one dedicated advanced heart failure center that has the expertise, the place, and the protocols for such a thing. We shouldn't hide behind the cost anymore. If there is a will, there is a way to find it. And ultimately, we need to also think about having a registry for organ donation, how to organize that process so we can divide the heart transplant program. Any other thoughts?
Thank you very much. Thank you. So we should move to this.